My name is Rebecca Willis. I'm a nurse practitioner student with Clemson University, and this is my second YouTube presentation. My patient is a 71-year-old Caucasian female who's coming to the office with a complaint of right-sided facial pain. The patient states that the pain started 2 days ago, and it radiates occasionally to her upper lip on the right side. She rates the pain as an 8 out of 10. She describes the pain as sharp, throbbing, and constant. She denies any recent infections or antibiotics. She does complain of some photophobia and scalp tenderness upon palpation. Her exam showed no neurologic deficits. She has no decrease in sensation or motor function of the right side of her face or the left side of her face. Her pupils are equal and reactive to light and accommodation. Photophobia was noted upon the eye exam. She has no redness or inflammation to her ears, nose, or throat. There was no abnormalities noted in her dental exam, no caries or abscesses, and her temporal pulses were equal on both sides. Her only medical history is hypertension. She takes lisinopril and hydrochlorothiazide for that, and it's well controlled. She denies drug, alcohol, or smoking, drug use, alcohol use, or smoking. She's not allergic to anything. The differential for this patient would include trigeminal neuralgia, migraine, headache, and temporal arteritis. There would be several other differentials as well, but since we're only doing 3, those are the 3 I chose. But the other ones could be problems with sinuses, jaw, or teeth, but we'll go with those 3. So to start with trigeminal neuralgia, there's no single test that can be used to diagnose trigeminal neuralgia. You have to rule out other causes of pain in that area of the face, such as problems with the jaw, teeth, or sinuses. Treatment can include anti-seizure drugs such as Neurontin. That would be 300 milligrams a day for the first day, and increasing that dosage by 300 milligrams every day until the pain is controlled, and that would be a maximum of 1,800 milligrams a day. Muscle relaxers and TCAs could also be used. Surgery is a last resort for trigeminal neuralgia. They can destroy part of the trigeminal nerve, but it does cause numbness to the affected part of the nerve. The other differential would be a migraine, and again, there's not a single test that can be done to diagnose a migraine. It would be important to assess whether this patient has a history of migraines, a family history of migraines. If this is the first time the patient's ever had a migraine, and there are some unusual symptoms, then a CAT scan of the head may be warranted. In this case, the patient had no history of a migraine, and the symptoms didn't quite sound like a migraine. There were no triggers, no vision changes. She didn't have an aura, and she had no history of migraines. So I would, if this were a migraine, I would teach the patient to keep a journal or a diary of what she eats, what kind of activity that she does, and when her migraines come, so that she can maybe start figuring out what the triggers for her migraine may be. And lastly, I would, for the temporal arteritis, I would draw hemoglobin, hematocrit, LFTs, SED rate, and CRP. With patients who have trigeminal neuralgia, the SED rate and CRP are almost always elevated. But to truly diagnose temporal arteritis, you would need a biopsy of the artery. I would automatically put the patient on aspirin, 81 milligrams PO every day, and methylprednisone, 4 milligrams PO every day, and go ahead and start that treatment prophylactically, because vision loss it could be a consequence of temporal arteritis. And this patient actually did have a biopsy of the temporal artery, and it came back positive. Temporal arteritis was her diagnosis.